All right. Respiratory emergencies. As an EMT, this is probably one of the more common ambulance calls that you'll have, or the type of patient that you'll see is somebody who's complaining of shortness of breath. Now, we'll start with a review of the anatomy and physiology of breathing. And breathing is both an active process and a passive process. Now, during a normal respiratory cycle, the diaphragm flattens, the intercostal muscles contract, and in doing so, the size of your chest is made much larger, kind of like a billows, if you're familiar with a billows. When the diaphragm flattens and the intercostal muscles contract, your chest rises. The pressure inside your chest becomes much less than what's outside in the room, and air rushes in to fill your lungs. Inspiration is the active process in the respiratory cycle. Again, it uses muscles, so it uses energy. And the more those muscles work and the harder somebody works to breathe, the more energy they're going to expend. It's the diaphragm as well as the intercostal muscles that allow your chest to rise, and air is then pulled into the lungs. Expiration is a passive process. The ribs and the rib muscles and the diaphragm relax, and the size of the chest decreases, and air is pushed out of the lungs from just the weight of the chest. Now, adequate breathing is breathing that is sufficient to support life. And adequate breathing is difficult to see, because if somebody's breathing normally, they have no obvious distress. They're able to speak in full sentences without having to stop to catch their breath. Their color's normal, their mental status is normal, they're oriented to who they are, where they are, and a general idea of time. Their chest rise is minimal. When breathing draws your attention, in other words, you look at the patient and you can tell that they're breathing, that usually indicates that they're working too hard to breathe. Adequate breathing may be determined by rate. And the normal respiratory rate for adults is 12 to 20 minutes, or 12 to 20 breaths per minute, effortlessly, without noise and without pain. We should not work to breathe. We should not make noise to breathe, and it shouldn't hurt to breathe as well. In children, they breathe a little faster, 15 to 30, and in infants, they breathe even faster, 25 to 50 breaths a minute would be normal for an infant. The rhythm is usually nice and regular, and if you put a stethoscope to the chest and listen to breath sounds, they're usually equal on both sides and easily auscultated. Inadequate breathing is breathing that's not sufficient enough to support life. Now, signs that somebody is breathing inadequately is they don't have an adequate rate or depth of chest rise. So the rate may be out of the normal range. If they're breathing less than 10 or breathing more than 24 a minute, if their rhythm is irregular, if their lung sounds are hard to see, or if their chest rise is not very adequate. Now, when we look at the airway of a person, the airway must be open in order for air to get into the lungs. And we have to pay particularly close attention to infants and children's airways because they do differ quite a bit from adults. Their airways are smaller. They're very easily obstructed. They have proportionally larger tongues, and so their tongue fills their mouth up. They have smaller, softer, more flexible tracheas, so when they get to tugging really hard, working hard to breathe, can actually collapse the trachea. They have less developed, less rigid cricoid cartilage, which again, the harder they work to breathe, the likely it may collapse the trachea. And they are heavily dependent on their diaphragm for breathing. So they breathe a lot with their belly. You see their belly pouch out as their chest kind of sunks in a little bit. So their intercostal muscles are not well developed. Signs of inadequate breathing in infants and children is that they often will have nasal flaring. Their nares will flare because the cartilage in their nares is not near as strong or hard as ours, and so when they start working hard to breathe, they'll get that nasal flaring. They may grunt, and grunting is something that an infant or a child will do in order to expand the air sacs in their lungs, in order to expand their alveoli. If they're grunting forcefully, it increases the pressure inside the chest, helping expand those airways so that they can exchange oxygen. Seesaw breathing, the harder they work, the more their abdomen pouches out and the deeper their chest sinks in. It's normal to see a little seesaw breathing in younger children, but if it's really obvious, then you know that they're working hard to breathe. And then retractions between the ribs, retractions below the clavicle, above the clavicle, retractions in the neck, using all their muscles in order to breathe. Another thing you would see might be head bobbing. When those muscles retract, they pull the head down towards the chest. Now, when we see somebody who has inadequate breathing, we need to step in. If their work of breathing is increased, if their breathing is inadequate, we need to assist their ventilation with supplemental oxygen. And we can do that with a pocket face mask with supplemental oxygen, or we can use a 2-rescuer bag mask valve technique with supplemental oxygen, and you'll practice both of those in lab. You also can use a flow restricted oxygen-powered ventilation device or a demand valve. And last and least effective is a 1-rescuer bag valve mask with supplemental oxygen. The chest should rise and fall with each breath, and rates should be about 12 per minute in adults if you're assisting ventilations, and about 20 per minute in children. Increasing pulse rates can indicate inadequate artificial ventilation in adults, where decreasing pulse rates or slowing pulses would indicate inadequate artificial ventilation in pediatric patients. When you see a slow pulse rate in a pediatric patient, I want you to think hypoxia, because the most common cause of bradycardia or slow heart rates in children is not enough oxygen. Now, whether or not a person complains of having trouble breathing really depends on their own subjective perception. Some people will say they're short of breath. Some people will say they can't breathe. Some people will say they're having difficulty breathing. They may tell you that their breathing feels labored. And the amount of distress felt may or may not reflect the actual severity of the condition, particularly in patients who chronically are short of breath. You know, when you have that patient who suffers from chronic obstructive pulmonary disease like emphysema or chronic bronchitis, they are chronically short of breath. So they learn that it's just part of their normal daily life, and they get accustomed to it. So even though they may appear, when you look at them, that they're working hard to breathe, they may not at all complain of shortness of breath, because it's normal for them to be short of breath all the time. Now, if I walked into a room and saw a patient sitting like this, I could see that their forehead was a little moist. I could see that they're in a position that we call the tripod. He's leaning forward, his hands are on his knees, he's attempting to maximize his ventilations. When assessing somebody with breathing difficulty, it's important to know, when did it begin, or what were you doing when it came on. The quality of the breathing, you might assess, do you have a cough with it? And if you do, is the cough productive? Are you bringing anything up? And if they are bringing something up, do they normally have a cough? And do they normally bring stuff up? Patients with chronic obstructive pulmonary disease, particularly chronic bronchitis, make more mucus than normal and cough mucus up all the time. So what you want to know is that if they do normally have a cough and it is productive, is this different than your normal production of mucus? Are you making more? Is it a different color? Does it taste different? You want to also know, do they have any pain or discomfort anywhere else in their body, and does that seem to spread to any other part of their body? Also note on a 0 to 10 scale, how bad is your breathing trouble? 0 being no trouble and 10 being the worst breathing problem you've ever had in your life. Give that a number. And it's really important to give it a number because you get a baseline for where they're at. And then if you give them oxygen, or you assist them with a breathing treatment, or you give them an EpiPen, depending on the cause of their shortness of breath, you can reassess them later to determine whether they're getting better or worse. You want to know how long they've had the feeling as well. Now, you want to observe for altered mental status because that's the first indicator in a patient who has gone into respiratory arrest, or respiratory failure. Your brain is the first organ to show dysfunction when you can no longer get enough oxygen. So you're going to see an altered mental status. They may be confused. You want to look at their chest for unusual anatomy. Is their chest very round like a barrel? People with barrel chests trap a lot of air inside their chest, and that's why it is so round and hyperinflated. And we see this in emphysemic patients. You want to look to see whether they're in the tripod position, which indicates a severity of shortness of breath, and are they sitting up with their feet dangling or leaning forward. You want to observe for an increase in work of breathing. Do they have retractions? Are they using their accessory muscles? Are their nasals flared? Are their lips pursed? By pursing their lips and exhaling out that narrow pursed opening, they increase something called PEEP, positive end expiratory pressure. And PEEP helps keep your alveoli inflated. Helps keep liquid out of the alveoli so that gas exchange can occur. You also want to note the number of words they can say without stopping. If they're speaking in just 2 or 3 word sentences before they have to take another breath, that patient is short of breath. Also look for pale, cyanotic, or flushed skin. Do they have any pedal or sacral edema, swelling of the ankles or lower legs that would indicate possibly heart failure? You want to measure their oxygen saturations, and if it's reliable and the reading is less than 95% in a person who's complaining of shortness of breath, we should administer oxygen. So here's a person in the tripod position. They may complain of tightness in their chest, or as you look at them, they may complain of numbness or tingling of the hands and feet. You may hear things like wheezing or snoring or stridor. They may be coughing or crowing or have a high-pitched barked cough, like a seal-like cough. Their nares may be flared. You also want to look for cyanosis, particularly in people of color. You're going to have to look, perhaps in areas of the body that would normally be lighter in color, like the palms of their hands, the tips of their fingers on the palm side. Are they straining hard to work? Are they using their intercostal muscles? Is their chest barrel-shaped? Remember that noisy breathing is obstructed breathing. Noisy breathing is obstructive breathing, and we need to be aware of that. Sorry, I'm not sure why I'm getting those errors, but back to breathing difficulty. Noisy breathing is obstructed breathing. And if we can hear audible wheezing without a stethoscope, that tells us those bronchioles are extremely narrowed. If the patient is gurgling, that tells us there's liquid in the back of their airways. If they're snoring, that's usually caused by their tongue obstructing their airway when they're lying flat on their back. If they are crowing or have stridor, that gives us an idea that they have an upper airway obstruction, where cough, wheezing would be a lower airway obstruction. You want to listen to lung sounds on both sides during both inspiration and expiration, because stridor and crowing is something that you typically hear on inspiration, where wheezing is something that you hear on expiration. You want to listen to the front. You also want to listen to the back. Wheezes are high-pitched whistles that you hear from air being pushed through narrowed airway passages. So wheezes equal bronchoconstriction. Crackles are fine crackling or bubbly sounds that you hear on inspiration, and they're caused by fluid in the alveoli or alveoli that pop open when the patient takes a deep breath. Rhonchi is a lower pitched sound. It resembles rattling or snoring in the lower airways, so you hear them in the lungs, and rhonchi are typically associated with fluid in the lungs. Stridor is a high-pitched, seal-like, barky cough sort of sound. It's usually heard on inspiration, and it's an indication of upper airway obstruction. You want to get a good set of vital signs, and also note if their pulse rate is elevated or their breathing rate is above or below normal. Is their rhythm regular or irregular? And how is their blood pressure? If a person is having breathing difficulty, you want to assure that their ventilations are adequate. If their breathing is inadequate, you have to begin artificial ventilation. But if their breathing is okay, you can put a non-rebreather mask at 15 liters a minute. So here's a flow meter on the end of a yoke of an oxygen tank, and it's set at 15 liters a minute for maximum flow. You want to put the patient in a position of comfort. That could be sitting upright. If they do have a meter dose inhaler, you certainly can help them administer their meter dose inhaler. And in some situations, you may be able to administer what's called CPAP, continuous positive airway pressure, a very important thing that provides pressure against the airway on inspiration and expiration, which helps keep the alveoli open so that gas exchange can take place. CPAP is blowing oxygen or air continuously at a low pressure into the airway, and this is going to prevent the alveoli from collapsing at the end of exhalation. It also will prevent fluid from shifting into the alveoli from the capillaries. Some common causes or some common uses for CPAP. The most common is going to be pulmonary edema from congestive heart failure. CPAP can also be used in drowning. It can be used in asthma and COPD. It can be used in pneumonia. It can be used in about any patient who is complaining of shortness of breath. But do remember that the patient has to be awake and oriented in order to receive CPAP. So if their mental status is altered, they can't get CPAP. If they're not breathing on their own, they can't get CPAP. CPAP, although it is positive airway pressure, CPAP is oxygenation. CPAP is not ventilation. If the patient is unable to sit up, or if they're in hypotension or shock, you don't want to give them CPAP because CPAP will make the shock worse. If they are nauseated and are vomiting, you don't want to give them CPAP because the mask has to be strapped tightly to their face and it may cause them to vomit. You don't want to give it if they have penetrating chest trauma because their incidence of perhaps developing a pneumothorax is higher. You don't want to give it to them if they're in shock because CPAP does lower the blood pressure. You don't want to give them to them if they have an upper GI bleed or a recent gastric surgery because CPAP, if the pressures are high enough, will dilate the esophagus and overinflate the belly with air. You don't want to give it when you can't get a good seal. If you can't get a good seal, all that pressure that you're trying to generate is lost. Some side effects of CPAP include hypotension, pneumothorax, an increased risk of aspiration, and then the drying of the corneas as air flows by the eyes. This is something that you may have to sell the patient. If I'm really, really short of breath and you're going to strap a mask tightly to my face, I may feel like I'm suffocating. So you might have to explain the procedure to the patient. You might have to start with a low level of CPAP of a pressure of 5, and then go up to 7.5 in about 10 minutes if there's little or no improvement. And the maximum pressure we would use with CPAP would be 10. So here's a CPAP harness and a mask and an EMT that's trying to perhaps coach this gentleman into wearing that tightly around his head in order to help him breathe. Once the CPAP is on and the patient is breathing through CPAP, you want to reassess their mental status, their vital signs, and most importantly, is it making them breathe easier? You should see an improvement in their breathing within minutes. If the patient deteriorates, remove the CPAP and begin ventilating the patient with a bag mask. If the saturations don't improve while the patient's on CPAP, you may need to do the same thing. So discontinue the CPAP and begin rescue breathing. Now we're going to look at some respiratory conditions that may cause inadequate breathing as well. The first one we're going to talk about is chronic obstructive pulmonary disease, or COPD. Now COPD includes emphysema, chronic bronchitis, black lung, farmer's lung, minor lung. The overwhelming majority of all COPD is caused by cigarette smoking. Chronic bronchitis, the bronchioles, the lining of the bronchioles is inflamed. The patient ends up producing lots and lots of excess mucus. The cells in the bronchioles that normally clear away mucus, these cilia, these little finger-like projections that push the mucus up into the larger airways so that it can be coughed out, they don't work, particularly in patients who smoke. So here is the chronic bronchitis patient who produces lots and lots of excess mucus in their alveoli. The excess mucus plugs up the alveoli, and gas exchange is not well. With emphysema, the alveoli walls break down. The surface area for respiratory gas exchange is greatly reduced. The lungs also lose their elasticity and they become stiff. And the end result is that they end up trapping carbon dioxide in their lungs. Now, that's typically how you and I know when to take a breath, is our carbon dioxide level rises. But in a COPD patient who chronically has CO2 retention, that stimulus to take a breath often is lost, and they have to rely on the oxygen content in their blood in order to trigger a breath. Now, asthma is a chronic disease with episodic exacerbations. So asthma is something that comes on suddenly. It may or may not have a trigger, like stress, certain smells, those sort of things. But during an asthma attack, the small bronchioles become even more narrowed. So bronchostriction occurs with asthma. Excess mucus production occurs with asthma. And it results in very small airway passages that are partially closed down or severely restricting airflow as a result of how narrow the passages are, as well as how full they are with mucus. Now, with asthma, the airflow is mainly restricted in one direction. So in other words, asthma patients typically don't have any problem getting air in. They just have problem getting air out. As a result, their lungs become hyperinflated. They remain inflated all the time, and they get the big barrel chest as a result of that. Pulmonary edema is the abnormal accumulation of fluid in the alveoli, and the most common cause of pulmonary edema in patients is going to be congestive heart failure, where the left side of the heart fails. When the left side of the heart fails, blood backs up into the lungs and causes acute pulmonary edema. Pulmonary edema can also occur from non-cardiogenic causes. Toxic inhalation may cause pulmonary edema in some patients as well. With the pulmonary edema, the pressure is going to build up in the pulmonary capillaries. The fluid crosses the thin barrier and accumulates in the alveoli, and then that fluid stuck in that lower airway makes it very difficult for oxygen to get into your bloodstream. The patient will complain of shortness of breath. They'll also be anxious, pale and sweaty, have tachycardia, hypertension, and respirations are rapid and labored, and their SATs are often low. In severe cases, you may hear something when you listen to the chest. They may be wheezing if the airways are just narrowed, and they may cough up frothy, usually white, but sometimes pink-tinged mucus. Treatment is to assess for adequate breathing, to administer high concentrations of oxygen, to keep the patient's legs up instead of, well, it says to keep them dependent, in other words, hanging over the cot, that sort of thing. And you may administer CPAP if the patient is awake in order to help flush that pulmonary edema out of there. Now, pneumonia is caused by a viral or bacterial infection in one or both lungs. It also can be caused by a fungi, but it results from inhalation of certain microbes. These microbes grow in the lungs and cause inflammation. Signs and symptoms of pneumonia is shortness of breath, coughing, severe fever or chills, and chest pain, which they often describe as being sharp and getting worse with a deep breath. They may also have a headache. They may be pale and sweaty, fatigued, and confused. Treatment for pneumonia is mostly supportive. So are they breathing adequately? And if they're not, reestablish that. Give them oxygen because they will need it, and then transport them for further examination and potential medication administration like IV antibiotics. Now, a spontaneous pneumothorax occurs when a lung spontaneously collapses, even though there's not been an injury. We see this in very tall, thin people. We see this in runners that don't have to be tall and thin. And people who smoke are at a much higher risk of spontaneous pneumothorax. Signs and symptoms are very sharp. Pain that increases with breathing, lung sounds are diminished on the side of the collapse, they're short of breath, it's hard to breathe, their SATs are low, and their heart rate is elevated. Treatment is initially to give them oxygen. CPAP is contraindicated, and they're going to end up with a chest tube in order to re-expand the lung. Now, pulmonary embolism is a large clot that blocks the pulmonary artery or the pulmonary veins. It's usually the result of a deep vein thrombosis, particularly in the legs. The chance of a pulmonary embolus increases from limb immobility, from local trauma to your lower extremities, or in patients who clot abnormally fast. Signs and symptoms of a pulmonary embolism, they're going to have that sharp pain that gets worse on inspiration, just like a pneumothorax. They're going to be short of breath, just like a pneumothorax. They're going to be anxious, coughing, sweaty skin that's pale or cyanotic. Their heart rate's going to be elevated. They're going to be tachypneic, and they may wheeze. However, 25% of all pulmonary emboli have, normal lung sounds and normal oxygen saturations. Pulmonary embolism is going to be very difficult to differentiate in the field from other things that cause that type of shortness of breath. So your best bet is to transport them to definitive care and make sure that you oxygenate them. Definitive care for somebody with a pulmonary embolus is either a clot buster, a drug that would dissolve that embolus, is going to be the most effective treatment. Epiglottitis is an infection causing swelling around or above the epiglottis. The epiglottis is a little leaf-shaped muscle that sits on top of the trachea and closes whenever you swallow, thereby preventing stuff from getting into your lungs. You've all probably had some liquid or something that's gotten by your epiglottis and causes a horrible coughing fit. So in severe cases of epiglottitis, the swelling can be so large that it actually obstructs the airway. You see this primarily in children. Signs and symptoms: a sore throat, drooling, very difficult to swallow. It hurts to swallow. They're febrile or feverish. They may be in an upright tripod position trying to breathe. They look sick. They may have a muffled hot potato voice, and you may hear inspiratory stridor as well. Treatment for epiglottitis is to keep the patient calm. Don't inspect the throat. Don't put anything in their mouth. Give them high concentrations of oxygen and transport them, hoping that their airway doesn't become completely obstructed. Cystic fibrosis is a genetic disease typically appearing in childhood. It causes thick, sticky mucus to accumulate in the lungs and the digestive tract. The mucus can become so thick and sticky that it can cause life-threatening lung infections as well as serious digestion problems. People with cystic fibrosis cough up large amounts of mucus. They're tired. They have frequent bouts of pneumonia. They have abdominal pain and distension. They cough up blood. They may be nauseated and have weight loss. People with cystic fibrosis typically know they have cystic fibrosis and can relay their symptoms to you. Treatment for cystic fibrosis: the caregiver is often the best resource for the baseline assessment of the patient as far as how is the patient normally act with their cystic fibrosis. Caregivers can often guide your treatment. They can assess for and treat for inadequate breathing and then transport. Viral respiratory infections are more and more common, or becoming more and more common, as we become more and more aware of foreign travelers who bring back with them viral diseases that we typically don't normally see. One of those infections would be like RSV, SARS, MERS. Those are all respiratory infections that, because they are viral, there really isn't treatment for them. Viral respiratory infections often start with sore or scratchy throats and sneezing, runny nose, a lot of upper airway stuff. Then they may develop fever and chills, and the virus moves down and spreads into the lungs and the airways, causing shortness of breath. The cough can be persistent. It may be a yellow or greenish sputum. Respiratory infections essentially are a infection of the respiratory tract. They're usually minor but can be serious, especially in patients who have underlying respiratory diseases like COPD. So if I have a COPD patient who gets an upper respiratory tract infection, it can be life-threatening. They often start with a sore, scratchy throat, runny nose, fever, chills, and they put that slide in there twice. Some of the treatment for respiratory infections might be a metered dose inhaler. If a person is prescribed one by their physician, they may have it, and you may be able to assist them with their metered dose inhaler. Just remember, before administering the inhaler, that you determine you have the right patient. It is the right time. They haven't just taken it a minute ago. It is the right medication, and you're giving the unit dose through a small volume nebulizer or a metered dose inhaler. Check the expiration date, shake the inhaler vigorously. The patient should be able to use it on their own, but if not, you can assist them. And if a spacer is available, you should use it. Have the patient exhale deeply, have the patient put their lips around the opening, and then press the inhaler to activate the spray as they inhale, which will absorb the medication deep into their lungs. Make sure the patient holds their breath as long as possible so that the medication can be absorbed. Now, small volume nebulizers are breathing treatments that they may do at home. This isn't like a little thing you put in your pocket. It's a machine that, when running, takes the oxygen in the air in the room, consolidates it into a pressure that runs through a hose into the bottom of a bowl where there is medication. The medication then becomes nebulized or into a fine mist or vapor where the patient can breathe the vapors in. Small-volume nebulizers create a continuous flow of aerosolized medication that can be taken during multiple breaths over several minutes, and it gives that patient greater exposure to the medication. So remember to determine if the patient's breathing is adequate or inadequate or absent. And if it's inadequate or absent, you need to step up. You need to do artificial ventilation. Assisting their ventilations if they're breathing somewhat on their own, but breathing less than 10 or greater than 24 can be a challenge. You want to choose the appropriate oxygenation and ventilation therapy for the patient. Consider whether to assist a patient or administer respiratory medications. Do you have the protocols and the medications that may help this patient? Does the patient present with a condition that fits the protocols? Consider whether to assist a patient with or administer respiratory medications. Ask yourself, are there any contraindications or risks to giving this patient a breathing treatment following my protocol? All right, so with that, that does end our discussion on respiratory emergencies. Again, if you have any questions, you know how to get a hold of me, so I'll be talking to you soon.